I just want to welcome you guys and thank you for joining right on time. We're gonna give people maybe another minute or so to join as we get started. I'm very excited about our second Curbside chat that talks about mentorship and career development and CL psychiatry with Lauren Deaver. And this has been an ongoing project. We had our first Curbside chat with Dr. Marilyn Powell back in April of 2024. So thank you for some of you who might be joining a second time to this series of chats. This is really a labor of love through our mentorship working group that is co-led by Lisa Namaro and Richard Shaw, who are here, and that I'm going to hand this off to next. So thank you. And as you're joining, please please put where you're from and the career stage that you're at in the chat box to help us understand who all is in our Curbside chat today. I'll hand it over to you, Lisa.
Great. Hi, welcome everyone. We have such a wonderful registration. We heard it was 150 people. So that is telling us that most people are very excited about hearing about mentorship and specifically early career launching. As Kiati said, we did have a Curbside chat back in April with Dr. Marilyn Powell, who's a very senior and esteemed child and adolescent psychiatrist. And today we thought we'd go to the other end of the developmental spectrum. And instead of speaking to somebody who is towards the end of their esteemed career, we thought we'd talk to somebody at the beginning of what will likely positively be an esteemed career. So, and we were very honored, Richard Shaw and I, to begin to think about how to develop a mentorship program. And so we did decide to do, at least at the beginning, more broad-based chats, but we hope to bring that down to more individualized mentorship, and you'll hear a little bit about that at the end. As I said, I'm Lisa Namaro. I was a medical director on a CL service in a somewhat small hospital, Connecticut Children's Medical Center. And for me, the exciting thing was that I got to enter a CL service at its very beginning. The good news was there were lots of opportunities. The downside was I didn't have that many colleagues. And so I very quickly learned that mentorship came from the American Academy of Child and Adolescent Psychiatry, specifically from the Physically Ill Child Committee. And they certainly helped hold my hand through my 30 years of being at Connecticut Children's. And so this is a wonderful way to give back to a great organization and a wonderful community. So I am going to turn it over to Richard Shaw, who will lead us off in the interview. As you guys see, the outline for today is that we're starting with the interview of Dr. Deaver, and then we will turn to a panel discussion that involves a few more of our colleagues who will introduce themselves. We then hope to open it up to Q&A, so get your chat box open and ready. And as Kiati said, if you ask a question, post a question, please tell us where you're from, where you are at in your career, and perhaps what location you are in our country, but maybe some of you are international, and we'd love to hear from you as well. And then we're going to tell you a little bit more about the mentorship opportunities and wrap it up at the end. So, Dr. Shaw, I'll hand it over to you.
Thanks so much, Lisa. Yeah, I'm Richard Shaw. I work at Stanford in the Children's Hospital there, and for many years I ran the Child Psychiatry Consult Service. I literally am at the other end of the spectrum, sort of heading more towards stepping down and cutting back my time. But I'm very excited to be here today and to introduce Lauren Deaver, who has very generously agreed to be our early childhood faculty member. And the format today is we're going to do some question and answer with Lauren about her current position and the different issues she's facing as she gets her service up and running. and then we'll have the panel discussion at the end. So Lauren is at Duke Medical Center, Duke University Medical Center. So hi, Lauren, and welcome.
Hi, excited to be here with everyone and to kind of talk about transition to practice stuff and being an early career psychiatrist.
Well, let's jump right in then, Lauren. So maybe you could tell us a little bit about how you came to Duke, what you were doing briefly before you took up your current role, and then if you wouldn't mind just saying a bit about your current position and yeah.
Yeah, absolutely. So I knew that I wanted to be a child psychiatrist from kind of the start at medical school. I did a couple of years teaching third grade in a very rural part of Mississippi before going to medical school at University of Mississippi with a goal really to be a child psychiatrist, and did my training in both adult and child at Massachusetts General Hospital, McLean Hospital up in Boston. I can see we have some people in various stages of training still here. So I will say I did not fast track. I did all 4 years of adult training and then went and did 2 years of child fellowship. I graduated fellowship, finished training in June, so just this past summer, and took a job, my kind of first big attending job at Duke University. And here I work in a couple different settings. So I am in the ED and the pediatric inpatient CL service. And then I also have some time in the outpatient clinic where I see some kids who are coming from the medical service. So it's a little bit of kind of like an outpatient CL focus in the clinic, but then also have some more kind of like general psychiatry kids who come to me that I see for longitudinal follow-up.
And what percent of your time is inpatient versus outpatient?
Yeah, so I do about 50% time inpatient, so like 24-ish weeks a year, and then 20-ish weeks, 80 clinic days, kind of when I'm not on service. So I go, for the most part, my schedule is structured to kind of go back and forth. I might have a week on a service and then a week in the clinic.
And if we talk specifically about the inpatient consult service, how is that staffed? How many people are there and
Yeah.
trainees?
Yeah, so when I was doing my job search in my final year of fellowship, I really knew that I wanted to work in pediatric consult liaison psychiatry. I really love that intersection of psychiatry and medicine and working with kids who are acutely ill in hospital-based settings. And I was really thinking about the type of, and of course that job really pulls for like academic medical centers that have pediatric hospitals and pediatric floors and kind of need pediatric CL psychiatrists. And I was also thinking about kind of the opportunities to be at a place where I would have some support and mentorship and supervision kind of as I was transitioning to attendinghood. And so I'm very lucky and fortunate and enjoy being part of a robust PDCL service here at Duke. So there's always 2 attendings on. So one attending covering the ED half of the service and one attending doing the inpatient pediatric CL service. And so there's lots of opportunity to kind of ask somebody questions or to think through challenging cases together during the day. And of course, we share a lot of cases who may start in the ED and then end up needing to go to the CL service for various reasons. And there's a kind of core group of us who rotate through the CL service, and that's probably 4 or 5 people, and then a larger pool that does occasional coverage and has a few weeks out of the year. And so there's a really nice mix of people who are really, really experienced and have a lot of clinical experience and are really good when you're like, oh my gosh, I don't know what to do with this case. And then people who are early career like me, who can kind of think through what is it like to come into a new system, and how did they learn the system, and how do they solve some of the problems that pop up, or challenges that pop up on the unit.
Mm. Yeah. And that's helpful. Thank you. And trainees, do you have fellows? Or?
Yes, so many trainees. So on the CL service and the ED service, there's almost always a child fellow who's working with me. We frequently have adult psychiatry residents who are rotating on both services. There's often a medical student on the inpatient CL service, and sometimes in the ED or the outpatient clinic. I also occasionally do some supervision in an outpatient like med psych clinic, and that's fellows seeing patients and then staffing with them. So a lot of opportunity to work with trainees and do supervision of trainees, which I had some experience with that as an adult resident and doing a chiefship and doing some supervision of junior trainees in that role, but hadn't actually had a ton of experience doing that as a child fellow to other kind of junior child fellow learners. And so that has been an area where it's been really fun. And it's also been a bit of a learning curve and how to kind of balance and navigate the different learners who are at different developmental stages in their own learning and have different needs on a busy service.
Mm-hmm. Mm-hmm. And as you've made this transition from, a fellow into an attending role, if we could talk first of all just about the sort of the clinical areas, and then maybe we'll move on to the sort of teaching, supervision, and more sort of research academic part of your job. What would you say have been, the biggest challenges, biggest surprises as you've stepped into these new shoes?
Yeah, I think one of the biggest challenges in making the transition to attending hood has been in part leaving the institution that I did all of my training at to come to a new state, a new institution, and have to make new relationships and learn a little bit of a new landscape in terms of what resources are available. I remember kind of in the first couple of months of starting work, kind of saying what I really miss the most about fellowship is the relationships that I built and all of the people that I knew, and that when I needed to talk to so-and-so in pediatrics, I knew where they were and how to find them, or I needed to talk to so-and-so in the emergency room and I knew who they were and how to find them, and I had a good working relationship with them. And so, it starting new to build all of those relationships again. It's a little challenging. It's fun. It's interesting. There are amazing people here. But it takes time. It takes time to get to know people. It takes time to get to learn a system. And so I definitely really found myself missing those relationships that I had kind of built over 6 years in training. And then, I think just, we'll come back to the kind of supervision and the mentorship piece, but those pieces of the system are also really important and new part of the learning.
Yeah, so it sounds, I'm assuming that a lot of the content of the work you were doing is clinically, you probably feel really solid, but
Yeah.
does it feel different being sort of in charge and making these decisions?
Imposter syndrome definitely reared its head very much so, and continues to do so intermittently. I'm very thankful, my training was very good. And so I would say most of the clinical cases that I see, I have an idea of what's going on and what we need to do and how to approach it. And then there's always that tension between kind of worrying about, am I on the right track? Am I thinking the right thoughts? I have all of these trainees who are looking at me kind of thinking, what are we doing? And other specialties who are kind of looking at me that I'm working with, who I want to have good relationships and make a good impression on. And so the content is very much the same and the clinical work is very much the same, but I definitely am feeling a little increased pressure to perform well and kind of make sure everybody's having a good learning experience, and that what needs to happen for the patients is happening, and that clinical care is really excellent and helpful and supportive. And I will say that's been an area where I've been very thankful to have a lot of other attendings who are on the service who I'm getting to know very quickly. Because when challenging cases come up or clinical uncertainty comes up, that is, I do feel like I have people who I can go to and ask questions. And that's been really lovely.
And how about in relation to your trainees and providing supervision? Did you feel you were prepared for that? And do you receive any kind of guidance or sort of, I don't know, mentorship around how to be a supervisor and provide supervision?
Yeah. So one of the areas that I really enjoy and did a lot of kind of work in as a fellow is medical education and kind of doing didactic teaching to junior learners and adult med ed principals. I think one of the newer parts is doing that more on the fly or at the bedside with learners, or kind of stepping back and, really observing fellows doing the interviews and having the opportunity to think through the decisions and coordinate the care and kind of being there as a support, but not the person who is doing it all. And that was actually a really big jump from fellowship. I was very task oriented in fellowship. I like to think about the cases. I like to do the work. I was very organized. I was very good at kind of getting things done. And as the attending who has learners on the service who then takes a step back and is providing more supervision, rather than actually kind of making sure it all gets done myself. That's hard. It's hard for me not to interrupt. That's something I'm still working on with my trainees. It's hard for me not to kind of constantly be like, did you do it? Did you do it? Did you do it? Because I want to know that it's done. I'm lucky that, the trainees here are really fantastic, and get things done. But it's definitely a change in the approach and kind of the role that I play on the team. And I do have, one of the things my own mentors in training mentored me around was in thinking about transitioning to attendinghood, was thinking about how do you build in mentorship, and that you should be getting kind of mentorship and having kind of clear mentorship. And that was something I talked about as I was taking this job and kind of thinking about the contract for this job. And so I have mentorship here and kind of, I meet monthly with the medical director of the service to talk about some of these things, including how to supervise learners and how that's going, and kind of different things that I'm working on in terms of supervising learners and giving learners opportunities to do the things and not kind of stepping in too quickly, which I think is a little bit of my tendency.
Well, that's fortunate you actually had that built in and the foresight to think about that when you applied for the job. Turning now just to sort of academic career, I'm curious if you could say a bit about what are your academic aspirations, and do you sort of have a roadmap of how you feel like you could develop a successful portfolio or set of interests? How much support do you have, and do you sort of have a vision, and does it feel like you kind of know how to approach that?
Yeah, I feel like I am in a place where I am working on what the vision is. I think there is a foundation in the vision of being a really excellent kind of clinical CL child psychiatrist, and that kind of this is the area of work that I want to be in. I had a lot of mentors talk a lot about the evolution of their careers, especially in training, and trying to take their advice and their reflections and being open to different opportunities and topics that come up. I think I've spent a lot of the first 6 months. I took a couple months of vacation and then started this job in August. So I've been here for about 6-ish months now. And it has really just been about getting the lay of the land and building those relationships. And now, especially in the last month or two, I've started to take on more teaching opportunities. So I've taught kind of some lecture to PGY1s this week, and did some like pediatric resident teaching, and have joined a couple quality improvement projects in areas of interest. And so I think I'm starting to feel out those opportunities, though I would say like a concrete vision for my career. This is where I want to be. This is the work I want to be doing, but like niche interests or how this is going to evolve is still, I think, flexible right now. And I do think that's an area in which, you know, I will start to pursue kind of more mentorship around, especially as, you know, kind of starting as a medical instructor and thinking about in academics, kind of how do you move up in rank? Like, what does that mean? What do I want that to look like? How do I build an academic resume? What would I even really want to be on it? I think like many child psychiatrists, I love catatonia. I've also found that I also really like infant delirium, which I actually didn't have a ton of exposure to in training, but there's a lot more infant delirium, like delirium in under 12-month-olds here, which I love seeing the babies and working with the families, and just kind of find that fascinating. So that may be an area, but I think still very much at the point where I'm like getting the lay of the land, trying to even figure out what I like and what I want to do, and now feeling a little bit more settled and comfortable, and kind of like taking on a little bit more in terms of academics stuff.
And do you have any protected time as part of your position?
Yeah, I have I think 10% protected time, so 0.1 at 0.1 FTE, that's like labeled academic time, which if I'm remembering correctly and kind of talking through this job and what I would be doing, part of the reason I took this job was because it did sound like there was a lot of support for developing areas of interest, for kind of some flexibility around, you know, if you're working on a service or in a clinic and it turns out not to be kind of what you're enjoying or doing, or you have interest in other directions, like there is support for making shifts and making changes, and you're not just kind of like trapped in one thing, and that leadership is really supportive of developing interests and niches and academic areas. Yeah.
Yeah, just maybe just one other question. I'm just curious, you know, there's a lot of talk about work-life balance, and, you know, often when we're starting out our careers, we're sort of working all the time, but also have other goals, personal goals. How does it feel it's been so far? And does it seem like this is a position that would allow you to develop these other aspects of yourself outside of work?
Yeah, so part of what brought us to North Carolina in particular is I have a daughter. She just turned 4, and a partner, and we are closer to my family, and more of our family supports here than we were in Boston. So thinking about a job in which I love the work and feel passionate about the work and like to do the work, and, you know, get to spend time with my family and feel like I can do things outside of work is really important to me. And I have found that my schedule is much better and more enjoyable, and I like the work more here as an attending. So for those who are trainees, like it is better, it is way better after training. And so I think I thought a lot about that, and actually talked a lot with my mentors about how do I think about a job and time in a job and structure in a job that I like and am passionate about and feel good in, and also can do these other things that are really important to me. And so far, this has been really excellent. And I've enjoyed the balance. And like my clinic weeks, I do 4 half days of clinic right now. And so I have kind of time outside of the clinic that I use some of it for my academic time, but then I also just have some like flex time, which has been really nice to have.
Yeah, one last question. Any sort of particular things you're hoping that maybe will be brought up in the panel discussion, things that you know, that really are things you're struggling with or hoping to learn, get some insights about?
Yeah, I mean, I think I would love to hear the panel's insights around, sorry, I got distracted by Kiati's message. I would love to hear the panel's insights around supervising junior trainees, and especially like as an early career psychiatrist, because I feel so close in like time to the trainees. How am I supervising like PGY or PGY 6s or CAP 2s when they've literally kind of like were separated by a year? And that feels a little odd at times. And so any thoughts or feedback on that? And then also just like learning new complex systems. I'm very lucky to be in a system where there's a lot of support and it is pretty well developed, but I know not everybody who starts these jobs is in the same sort of system. So speaking to people who may kind of not be in similar roles, and then mentorship. I think thinking about how should I be developing mentorship, thinking about mentorship, utilizing mentorship, especially as I'm thinking about like, what is my vision for my career, which is such a big question that I am still really thinking about.
Thanks so much, Lauren. That's a great way to get us started. I'm going to turn it back over to Lisa.
Lauren, that was wonderful. Thank you so much. And feel free to speak up during the panel as well. I am going to invite Kieran and Chase to join us now as members of our panel. And I'm going to, before I ask you guys a question, I'm going to ask both of you to do a little intro of yourselves. Kieran? Sorry.
Okay. So I'm Kiran Khalid. I'm an early career psychiatrist, currently at Virginia Tech Carilion School of Medicine. I do my clinical roles include running the consult service at our hospital, which is not a freestanding children's hospital, but we have a pediatric consult service and doing inpatient pediatric ped psych work. And then one of the academic hats that I wear is that of a med student clerkship director for our institution as well. And I'm really excited to be here. It was really good to hear, your experiences, Lauren.
Chase, and then Kieran, get ready because I'm going to come back to you about a question.
Awesome. Hi, so I'm Chase Samsel. I'm a triple board clinician. I'm the medical director of our psychiatry consultation service here at Boston Children's Hospital. Wear a couple different hats. I'm also associate training director for our CAP fellowship and triple board program. And most of my clinical time is spent specializing in transplant psychiatry. And I think between Kieran and I, she's the early career CL psychiatrist, and I'm the mid-career CL psychiatrist, and really excited to be here.
We were going to have the audience figure that out, Chase, who's the most, Kieran, so I think you and I might be two people on this panel who came to institutions. My institution was freestanding pediatrics, but within a medical school setting, but relatively undersourced, as we might say. And I think that you also are. So maybe you could start us off describing that a little bit, because I think that makes your experience a little different than Lauren's, and exactly what you found in your system and how you first sort of got to know your system, which I think was new for you.
Our hospital is a level 1 trauma center and has the only pediatric ICU in Southwest Virginia. So there's a large sort of geographical area that we serve, but it is not a freestanding children's hospital. Yet again, being the trauma center and having the only PICU in the area, we do end up getting a lot of kids who are very sick, and so may need psychiatric care as well. I think that it's been an interesting experience because my training program was a freestanding children's hospital. And so coming from that, I think it was interesting to learn the new system in a new state. So kind of like, resonating with some of Lauren's experiences of learning resources in a new area. I was very fortunate that our team and the attendings running the service before me were still within the system. And so I was able to get some intra-institutional mentorship through them, find out about resources. And then I think I was fortunate that wearing the inpatient hat, I was able to work with the social workers both on the inpatient psych service and having some time with the peds floor social workers as well, to trying to get to know the resources in the area. But honestly, like, I think for the first few months when I would learn about a service, there were a lot of times where I would call and find out like exactly what they do, what they were able to offer, and to start to build a little repository of resources in the area and community resources that I could refer patients to. And so I've had a better understanding of for my own self what we can offer and refer patients to. So it's been an interesting learning process.
So Chase, how did you, I think you've been, have you been at Boston Children really since training? And how did you, because that's a rather large, complex system, how did you think about that when you first arrived? Would you have done anything differently? What would you tell people are sort of some of the main ways to get to know the complexity of a system?
Yeah, so yes, I've been here at Boston Children's for all 12 years of my attendingdom, and somewhat similar, it sounds like, to Lauren. I started off half-time on the general CL service and half-time doing psychosocial oncology in the outpatient clinic, and also seeing those patients when they came to the floors. So, you know, it just takes time. I think is one of the things to know it, and I think one of the other sides to that is that we in CL get to know systems a heck of a lot better than other people. So while it may feel hard and we're new settings, new places to get to know those things, I think we should give ourselves a little bit of grace, because we are both hungry and super aware of systems and nuances and differences and all those aspects that are critical to being good liaisons. And we do it pretty well. I think it just takes a little bit of time. I think one of the phrases that sort of stands out to me is street cred, that it just takes a little bit of time to like really get on the inside circle with a lot of the colleagues that you work with. And it usually takes just a couple of, really tough situations and challenges and cases with people before they're going to remember your name now, and they're going to look to you for all their questions, and they're going to reach out via email whenever their nephew, may have ADHD and they're looking for referrals, and you really know that you've got the buy-in. And it takes some time, especially when, as Lauren did, you trained in a single place for 6 years. I trained at Brown for 5 years before I came up to Boston Children's. And despite it only being 40 miles away, it is a completely different system and a completely different place with all kinds of new faces. And being at a large system means that you really just have to go through the progression of working with those different teams. We have 500 beds in Boston Children's Hospital. There's, 25 different specialty services. Like, I need to have different interface with different folks over time to start to get at that point where we've had enough volume, like we've had enough substrate working together to be able to understand, the audience, and for them to get to know me in some ways.
How long do you think when you think about time, how long did it take you to feel comfortable and like you knew the system and you were an expert and kind of people had buy-in and were coming to you?
Yeah, I mean, I think for the general feeling, probably 2 or 3 years. It probably takes 2 or 3 years to get there. And I've, now in my position as medical director for the past, 5+ years, I tell that to all of the different psychiatry and psychology attendings we have on our service. And time again, they've said, yeah, like, I really get it. I thought I had it before, but now I really get it. Or, wow, everything's so much easier than it used to be. It's really at that 3-year mark, I think, for most people. The caveat to that is if you're really well embedded on a team, right? So the oncology kids and the stem cell transplant kids and docs and nurses, because I was seeing them and integrated doing outpatient CL, like that was so much quicker. Like, I knew that I had so much more content expertise and FaceTime with those folks. And in the opposite way, there might be some places where you're consulted less, or some teams that are smaller that don't work as often, that is maybe going to take a little bit more time to get to know them. But I think still that overall, like, I'm a CL attending and I'm doing well and I've got this, and things just take so much less effort to have such a good, end product. I think it's really probably that sweet spot is probably 3 years. But Kieran, I'd be interested if you're feeling that way, if you feel like, where on that trajectory you're getting to, or if you've noticed some of that.
Yeah, I think I definitely agree with like it taking time. I think I'm sort of at the in the middle of my ECP sort of journey, and so it definitely did take time to get to know those know people and know services, and I think initially sort of like taking the time to introduce myself, saying that I'm on the CL service now, and reaching out to the subspecialists as well. I think that our system, getting to know our system, but also as things have changed, people have come and gone. I think that has been both interesting and sometimes sort of like challenging in some ways as well, to try to rebuild, like not rebuild relationships, but like sort of I guess sort of build on what was there before, but with a new person. I think that it has taken time, and I think given the unique sort of place that we're at, and because we serve a lot of the rural Southwest Virginia, and so I think kind of learning about resources in far out areas has been hard. A lot of times we can get kids who are from 3 hours away or 4 hours away, and it might be really difficult to try and get, you just don't have to learn about services here, but also services in the neighboring counties as well. And so I feel like sometimes I felt like just when I feel like I've got it, there's like one county that pops up and I'm like, oh, I don't really know about this one. But then it's like you said, it's interesting, and it's exciting to kind of try and find out what is out there, and it takes time, and you need time to do that.
I was going to say,
Richard,
I think one of the, sorry, Lisa. I was just going to say, I think one of the advantages of coming in as a new faculty person is that you actually have the option of reaching out to talk with different subspecialties and leaders of services, because I think most pediatricians want psych services, but just assume they can't get them or can't get more. And sometimes if you go about it saying you're doing a needs assessment, I remember that was one of the things we did early in our service, was to go around to all of the different specialties, meet with the chiefs, find out what their population was, what kind of issues were coming up, what ideally they would want from psychiatry or psychology. And that not only, I think, shows your interest in working with them and helping them, but it can generate potential ideas for more collaborations, maybe going to the hospital to request more resources, putting together plans for development of services or research. So I think that that new status in a hospital gives you an opportunity to sort of help people look at things with fresh eyes.
Yeah, I was going to add on a somewhat granular level, when in Connecticut we finally got our own MCPAP program, we were required by the program coordinators, which is that access, the Child Psychiatry Access Program. We were required to get in our cars and drive to each pediatrician's office in order for them to sign up. And we literally, this was before COVID, we literally had to meet with them and then show that we met with them by signing a paper. And a pediatric practice couldn't sign up for this program until they met with us. And although Connecticut's not a big state, driving around felt really weary, particularly when I was trying to do CL and access program and whatever. But I can tell you that what I learned from that experience, and also on CL, is that you take every interaction you have with the people who are consulting you, and you make it meaningful, just like you would starting a friendship, and you maybe even get to know them a little bit, like, hey, where did you try, where are you from? And so, with short time, you just want to kind of think about it almost molecularly, that anytime you collide with a colleague, or with a staff, with a nurse, with anyone, because the other part of CL that is so unique is that we're very used to focusing on the patient and their family, and of course that's so incredibly important. On CL, the person you need to please is the person who consulted you. And CL came from the corporate world back when, and that's how it was developed to be your consultant, which is a very different model. But when you define that in your head, you realize like the person that I really have to kind of get to know where they're coming from, but also sort of satisfy, in addition to the patient and the family, is the person who consulted me. And building, each one of those interactions into some sort of meaningful connection, I think, is another way to think about things. Richard, you wrote a book, which became one of the relatively few books there are, textbooks in CL psychiatry. How did that opportunity come your way? And what were you thinking when you were asked to write that? So speaking about how you take opportunities in academics.
Yeah, I think, the word imposter syndrome you used, Lauren, when I started the service, I felt like I was one chapter ahead of my trainees and, giving lectures on something I felt I had to look them up the evening before. I think many opportunities, whether it's research or program development or some writing project, a lot of it is luck. A lot of it is connections. It's, it just so happened that the editor of the publisher was at Stanford. And one advice I would certainly have for new faculty is to set up regular meetings with your chair and your division chief. Often the chairs are a little bit more removed, but chairs, a lot of opportunities come across their desks, and they can hand those out to you if they know that you're interested. So I was in one of my regular meetings and the chair asked if there was a book. I said no, and he said, well, call this person, you should write it. It was sort of as simple as that. And I definitely had the imposter syndrome qualities, but I think that, I think that there's so much to be done, and when these opportunities come up, you should feel empowered. You really are, the new generation, and you have the skills and expertise, and I definitely think that that imposter syndrome is something we fight with, but also need to keep it in its place.
Chase, how have you negotiated the, hey, Chase, why don't you write a book? Or, hey, why don't you do some research in the psychosocial aspects of oncology treatment? How have you said no? If you said no, how? Or how many times did you say yes?
Some of the trainees and train directors and I joke that we should write a book on the power of no, but that's a little bit of a contradiction in terms, or we do actually have a 5-minute lecture about the power of no. And I think this is a great thing to talk about, not only for like our own careers, but also the interpersonal dynamics of CL. Right? It's such a frequent phrase that we hear on our medical floors all the time from our pediatric attending colleagues or trainees of like, wow, like you all said no to something. That doesn't really happen in pediatric hospitals, that these things, setting limits are really important for us personally, academically, clinically, for our patients, families, and staff. And I'm going to sort of contradict this a little bit, but I think early in one's career, it's important to say yes, and fight that imposter syndrome, to dive into things, to say yes. You got to get out there. And sometimes it's hard, as you were kind of talking about, Lauren. You have some interests, like I'm curious to see where these go. Oh, infant delirium. That's not something I have much experience, but it's all around here. And it's okay. And I think when you're thinking about like the beginning of your career, you need to try on some hats. And we try on lots of hats in CL, and seeing how those things go. It's much more appropriate. And I'm certainly getting a lot of advice from my mentors and chairs that in your mid-career, that's when you should really start to specialize and be known for certain things. And that can come later. First, you got to build up a solid base, whether that's teaching, academic specific interests and research and writing. But I think it's really been much more of an undoing and finding ways to hand out other things. I'm nowhere near a chair, but like thinking about trainees and CAP fellows, or thinking about early career psychologists and some of our psychology colleagues, to think about how to find or say, you would be a really great addition to this committee with me, or like, actually, I need to roll off, and this makes much more sense for you to be on now, to more intensively pour myself into very specific expertise things. So less of a lot of different things, but more of like doing multiple things or deep work with just a few things at this point in my career. And I'm glad to have gotten that mentorship advice. Speaking about the importance of mentorship, that was really helpful to guide me. I think I was definitely very eager young attending with lots of potentials, as I think everyone is that we're talking to now, with you, Lauren, with Karen, with other folks in the audience too. And it's okay to say yes to a lot of things, especially things you're most excited about. And I'm sure all of us have had and will continue to have the experience where we're sort of voluntold by our chairs and chiefs to do certain things. Those are inevitable when they come. But I think as time goes on, you just progressively say no to more and more things and do what you're most are interested in or most have to do.
And Chase, to your point, and for Lauren and Kieran, and the other early career psychiatrists, I think most people would say that their area of specialty and or research came to them because they just happened to be in the right place at the right time. And you will see most colleagues would tell you that story, unless you were specifically trained as a researcher and came out with your PhD or did a research fellowship. My areas have been clinical pathway development and pharmacogenetics, and neither of them would I have said that I was interested in, knew about when I first was a young attending. And so I love that model, Chase, where you say sort of the first couple years, watch for opportunities for sure. Say no somewhat sparingly, but no, it's possible. But mostly you're creating your base from which things will float by you and then perhaps stick.
I love that, Lisa. I think it reminds me a lot of when we meet some of our patients who are high schoolers and we talk about what they want to be or do when they grow up, and they kind of have a limited knowledge about what those possibilities are, right? Like, say, not until someone gets out in the workforce in their mid-20s and they're like, do they even like figure out what they're gonna do with their career? And I think the same thing can be thought of like in narrowing the funnel and CL as we get to see more and more things. But you said something really important too, which is that I think this is not just for our early career, because this is not just saying yes when people are asking you to do things or tell you to do things. This is also looking for opportunities, and both academically and career-wise, I think it's really important to adopt a couple phrases that have been really helpful for me. One, we should write this up. Would you be interested in writing this up, right? You have a really interesting case report, or a phenomenon that keeps reoccurring, or you're working on some new QI intervention, talking with your pediatric colleagues, like, we should write this up, right? So many of them may actually be publish or perish, unlike a lot of us. And writing on those coattails, learning about research process, getting on working groups, at the hospital, that's a great opportunity. Then finding a way to take a part of whatever project you're doing to say, I'll be first author on this. And, it's a great experience, I think, for a lot of people coming into early and then to mid-career work. And then also, saying that you're just interested, even if it's not working research-wise, but interested in working on certain things, patterns you notice, right? We're great at being noticers in CL and recognizing patterns. And if something keeps coming up, to find good allies around that, to think about a working group or a committee or some sort of new clinical pathway, right?
All right, Chase, so I have to grab that pattern because you absolutely read my mind. So when you see something that's really unique or unusual in a patient, and you look around and you see, did anyone else just see what I just saw? Does anyone think that's really unique? And Lauren, I have a Duke related story because before there was autoimmune encephalitis, we didn't know what we were calling this thing that we were seeing, which is acute onset neuropsychiatric changes. And it was so clearly different than what a classic standard clinical trajectory of a psychiatric disorder was. And so we developed at our hospital, we called it peri-infectious encephalopathy. And there wasn't anything on it, and neurology, when I heard that Gina Moonihan was looking into autoimmune encephalitis, and I reached out to her at one AACAP meeting and said, "Oh my gosh, I'm seeing this stuff. You're doing this work. Let's do it together." So it is so important. We train in medical school to look for patterns. Susan Sweeto and her PANDAS work was, this kid that I see is not like all the other kids that I have seen. There is something different about this kid. And so follow your gut on that. There is still so much we don't know, and there's still so many patterns we want to, and we could use the listserv too. Karen, what has come your way where you have said yes or no?
As y'all were talking, I was sort of, thinking about my experiences as well, and I feel like I definitely agree with the importance of mentors and also sponsors who sort of spoken my name for opportunities and said Kiran would be a good fit for some of these things. I think also I have found it very important both to have like institutional mentors, but also, extra institutional mentors as well. I remember I was at an AACAP mentorship event at a meeting, at one of the annual meetings, where I was struck by two things. One was I said, well, I really want to do this sort of, career track right now. What if I'm not interested in it? Like 3 years later, I do it and I'm like, this is really not for me. And I remember one of the life members said to me, well, then you have learned a really good skill and you would have learned a really good lesson about yourself. And you can take both those things with you to the next thing that you do. And I found that to be a very inspiring and also like hopeful way of looking at it. And I think the other piece is that, a lot of things have come through. I think for me through AACAP, I think we're talking about like relationship building and, I'm an avid reader of the Physically Ill Child Committee listserv because I learned so much reading it, being at, we're a smaller institution. So sometimes we don't end up seeing some of the really, some things that are being seen maybe at bigger tertiary standalone hospitals. And so I think it's been very helpful that way. I've gotten to be involved with the PCL psychiatry like curriculum development, and so I think all of that has been through a lot of it has been through AACAP and through like national organizations, and so I think for me, like AACAP has had a big role in things that have come my way. The other thing that somebody had told me at that meeting, mentorship event, was, to think of mentorship as a mosaic model, as well as to, think about if I was a very excited trainee and I said, I'm really interested in a lot of different things. And they encouraged me to think about, is there a way to consolidate some of those interests and really build a, sort of niche, but also to be mindful, of just the dynamic process that is the evolution of interest as an early career psychiatrist. And, I think that's what I'm hearing all of you say as well.
Yeah, the relationship building and the importance of mentorship really resonate with me, because I think all of the things that I have learned about myself and have been really interested in and have developed kind of skills and have really relied on having really good mentorship, and that mentorship has often come through like relationship building. I wouldn't be here had a mentor not said, you should really think about AACAP or ACLP or like get involved with some organization. And then the PIC committee was looking for like a fellow, and my mentor was like, maybe you should apply to this. And here I am. So I think the mentorship and the relationship building are just so key to wherever we land, kind of how we move forward and what we do.
Awesome. So Lauren, anything else you wanted to ask the panel? We actually are getting to the time where we were going to open it up for Q&A for all the wonderful people who have been listening. Any last things?
Yeah, I could pick brains with questions for a long time, but I am seeing some actually really interesting questions coming up in the chat. So I will defer to them so that we have time for that.
Awesome.
So
Karen, did you want to quickly talk about the WhatsApp group? Or
right. So the other, we're speaking of relationship building, just, on that, we have the early career child psychiatrists, we have a WhatsApp group. And so if folks are, all early career child psychiatrists are welcome to join it. It has led to a lot of, again, relationship building, lots of ideas, lots of opportunities to say yes to things, lots of opportunities to say, like, hey, I'm maybe not me, but here's this other, ECP who might be really interested in this. And also, just talking about our own journeys through these, earlier career times. So if folks are interested, please let me know. We can get people at it.
Awesome. Kiara, you've been watching the chat.
Yes.
Do you want to lead us off?
Yes,
with
happy to
questions?
back in. I'm just want to say thank you to all of you, Lauren, especially for being brave and with the interview, and then sharing your experiences, and then all the panelists, and really starting off a thoughtful conversation. I think we were just talking about mentorship, and so maybe I will pick up on a question that's related that came in from Christina Joy. There's two parts to her question, but I'll start with the part that relates to mentorship, which talks about, many of you talked about moving to a new program, a new state. And when you're new to a place, how do you go about finding mentors in a new institution that you did not train in? Any pointers about what could be helpful in that scenario?
I think it should be part of your discussion with your chair or whoever is hiring you, ideally, before you accept the job. But if you're in the job, it's not too late to go and say, I'm looking for mentors. And mentors can be for different parts of your role. You could have a research mentor, you could have a clinical mentor, you could have mentors for different things. So I think most of us in our careers have had several mentors, some at the same time. So, but I think it's very easy for chairs and division chiefs not to necessarily be thinking about the needs of junior faculty. Unfortunately, they're maybe not quite aware again of what someone's going through when they start a new job. So, really asking, saying, I want help, and in many medical centers, there's a lot of expertise and faculty that could be available.
I think the asking that Richard just mentions just has to be underscored so much. I think this is one of the biggest dilemmas and challenges that early career CL folks have, or any early career teens have, is being able to assert yourself and to be able to talk about what your needs are, right? Like, you're inherently saying, I need mentorship, I want these things, but I think it's like, for those of you that got good couples therapy training and CAP fellowship, right? Like, you just have to literally say what your needs are. You got to say what those things are. And even if it's not well formed, that you're just really looking for a good mentorship, that's important. Or if that's more supervision, if you're having trouble trying to disentangle supervision and mentorship, that's just really something that's important to you, that you need that. I would also say, in addition to what Richard said, with different like research, clinical teaching mentors, to get some of that available, is that especially in smaller institutions, if you can't find exactly what you're looking for in terms of a child and adolescent psychiatrist or even adult psychiatrist, like, there can be some really powerful mentors that are outside of a psychiatry department. And sometimes it's important to have mentors outside of a psychiatry department. I have some of my mentors, their most favored and helpful experiences have been having a urology chair mentor, or having a pediatric hospitalist mentor who is mid-career for them, and thinking about bouncing off ideas and meeting with them. That really important to think broadly if you can, especially if you're at an institution or place where there's not a huge child and psychiatry department or base, to be flexible. And also think about people outside of your institution too, as a future plug for our mentorship program that people are talking about later.
I definitely agree with the idea of like asking what we need. And, I agree with, I appreciate what you're saying just about like reaching out and maybe needing to, assessing your need and asking for what you need, whether that is like, I need to talk to somebody. When I first moved, I we sort of requested to meet together to talk about like resources and how to like think about and understand resources in the region. And I think over the years that has become like those have become really good, important relationships, as well as, you know, have given me sort of some opportunities to ask like, hey, I'm the only one on the service right now. I've got this really challenging case. Do you have a few minutes today? Can we talk about this? Do you know, I just want to pick your brain about this. And that has been quite helpful as well within the institution and outside as well.
Yeah, and I also think about not just kind of the physician mentorship, but also the people in the system, social workers, psychologists, behavioral health case managers who are extremely experienced and like know the systems well and navigate the systems well, and like building relationships with them. I know I'm actually on service in the ED this week, and I'm in the behavioral health case manager office like every day being like, okay, how does the system work? What are the resources for this particular kid with this particular insurance? Like, we had a pretty complicated ESS case today, and that it was really the behavioral health case manager, who's excellent and knows the system super, super well, who was helping me kind of figure out what's the best way to go about this, like make a plan for this kid. So I also just think kind of like talking through cases, asking questions. I send a lot of emails around resources. Like, I have this kind of case, like, what do I do? What do you think? And I just ask a lot of people a lot of questions all of the time.
So Lauren, you did a great job of answering the other part of her question, which was basically what you said, is how, when you're new to a state or an institution, how do you learn about the various resources for referral sources and what services are available in a new institution? So I think you've already answered a lot of it, but if anybody else wants to add anything, I would welcome them.
I'm just going to add something really granular again, which is that every institution has an org chart, and it's really helpful to look at it and to see both within a behavioral health system who's who, and also within the pediatric who's who, and even COO, CEO, because complex cases like long length of stays, kids who are busting up their room on the medical floor, they go to COOs and CEOs. And so you know, and then you get called to these meetings. So you want to know who those folks are as well. And just concretely, it's really helpful to look at an org chart, and know who's who and who's in relationship to who.
Sounds great.
Yeah, I think meeting with those people in the org chart too.
Yeah.
It's great that you just talked about social workers and case managers, but every time you're faced with a dilemma, noticing every time you're faced with a dilemma and you're like, wow, I don't think I know the SNFs or residential living facilities in this area. You're talking around like, who knows this? Like, can I take that person out to coffee for 30 minutes or lunch sometime in the next 2 weeks? And asking and telling what you need, like, what do you think I need to know about everything to do with placement, you know, in residentials around here? Or like, who would best be able to like walk me through what the involuntary certification process in this new state is, or what are the norms around that? And it's also an opportunity to create a legacy document and maybe help out a future colleague who will be in your shoes at some other point, to be able to make a bit of a curriculum out of that. Or, you know, sometimes people have on-call documents that answer all these things, and you don't find it out until like 6 months in, when you do your first on-call weekend, and you're like, wow, I really wish I would have had this earlier. It could have helped orient me to my daily work, not just my on-call work.
I think that two things that I also found really helpful were, when I first started, I sort of had I kept a working document on OneDrive on, you know, which was evolving about resources in the region, and especially like folks who were able to provide specialized care as well, and that kept evolving, and I learned a lot through that. The other thing my medical education had putting that on is I also would do a lot of teaching in front of the social workers, especially about the processes of like involuntary holds, and to ask them to like correct me if I get anything wrong, because retention after, you know, you teach is much higher. And so, you know, I think over time it really helped me do that as well.
Great, thank you. So I'm going to move to another question that had come up, you know, related to some of the administrative people that you talked about earlier, which was from Michael Chu saying, there is a lot of focus now on looking at RVUs for CL and ED psychiatrists. And increasingly, there's a triaging where less complex cases might be seen by non-psychiatry colleagues, and then the more complex cases are being seen by psychiatrists, which might then impact, the RVU generation. So their question is there a way, is there an average number of CL patients or new consults or follow-ups for attendings or residents, and how, maybe broadly, I might broaden the question, is how do people manage this within their CL service, balance those things?
Well, I'll say a word about RVUs. I mean, I think there's an inherent tension between divisions and faculty members, which is, division chiefs want you to get your RVUs, and, you need to get promoted, and they're not always consistent, those two goals. So I think it's always going to be a struggle. I think in reality, if you don't make your RVUs, probably not much is going to happen in the big picture if you're doing a good job. But if you don't meet your criteria for promotion, then you're not going to be promoted. And so I do think you have to prioritize your career. It's always good to know if these RVUs are reasonable. And I think just keeping in mind that probably there's never going to be enough RVUs. Division chiefs and chairs are never going to be happy. They're always going to keep raising your targets and always going to be asking you to do more. And at some point, it's that, saying no. And even if it's an internal no, that, today I'm actually going to finish that paper, because if I don't do that, there's going to be bigger long-term consequences. So, I just think I'm curious what other people have to say to that. But I think it is an unfortunate trend now that with the sort of monetization of our specialty, often academic careers get kind of sort of left behind, and the division chiefs are not always looking out for everyone's best interests.
I'm going to shout out to some of Richard Shaw's great work, speaking of writing papers, but I'm thinking of him and Dave Damaso's study that helped utilize the pick listserv and looking at averages of what different folks see, and those two publications I think have been really helpful. And another standout phrase for me is the word value add, or I guess two words, value add of what we do. I think another person in the chat had a question around like, oh, adult CL versus child CL, and the child CL seems shrinking. And I think it's really, really important to find opportunities to highlight those value adds, whether those are like root cause analysis, SIRS events that happen that show you the complexity, whether it's talking about the stakeholders, like who are those people? Are those the peds hospitalists, or the different nursing managers and leaders that really value your work and can speak to how this is different than adult work? And you can't just go by and briefly see tons of patients and build lots of quick follow-up codes. That, like, highlighting those, putting those in your pocket and finding your allies to speak to that is important. Parental surveys, parental experiences, and shout outs about how this is just fundamentally different than ways that RVUs unfortunately do not and currently cannot, explain, is a really, really important thing. And again, affirming yourself of what's really, really important to your chairs or division chiefs, that this is what you want to do if more of your time is being eaten away. You can't ultimately change necessarily everything that your division chairs and chiefs think about those things, but you can emphasize what's important with hopes of being able to get more support around that, and in this tough situation navigating, as Richard said.
Thank you. I'm gonna, in the interest of time, there's still, questions. I think a lot of questions about outpatient CL work. We'll try our best to address them after, if we don't get them today. Although, I think our committee focuses more squarely on the more traditional inpatient CL work. I know that there's never going to be enough time for all the questions that anybody can have about navigating early career as a CL psychiatrist. Our hope is, in starting this series, is to maybe next move to a small group model, to see if small group mentorship is something that we want to explore that possibility. Quentin, I don't know if you're on here and can advance some slides. So what we have is a group of really seasoned, well rounded, respected mentors in the space, all have different areas of specializations that have volunteered their time to help people as we explore this model for more ongoing mentorship versus these, and we might still have these curbside chats, but really having a parallel model. So we would love to hear from you guys if you're interested in this, and if so, what kinds of things you would be looking to get from that. There is a QR code that you can scan. Quentin, do you want to move to the next slide? Thank you. That talks about your interest in mentorship and really just help give us a sense of what you might be looking for and where you're at with that. Again, I want to thank everybody for joining today, to the panelists, for your time. I'll just say, as one of the co-chairs with Nasumalis for the Physically Ill Child Committee, we are very committed to being a resource for everybody who wants to do PED-CL work and connect you. Maybe you are lucky and have a great team, you're at Boston Children's or one of the large institutions, or you're really the one child CL person in your entire system. We want to be a home for you where you can feel like that's your tribe. So please join the PIC listserv if you're not already on it. Our meetings at AACAP are open meetings, so please don't hesitate. We'd love to meet as many of you over the course of your careers as possible. So I hope this is super helpful. And I think we are right at time, or maybe.
I think we were just going to have Lauren do a final wrap up, and then we'll be done at 7:15. The one thing we were teasing Kieran about the 21st Century WhatsApp group. The other thing I would say you should do with your phone is every time you meet a colleague, get their cell phone number and put it in your phone. I mean, maybe you guys have, the HIPAA, whatever, but so that any outpatient doc you talk to sitting in the ER and you have to call somebody because you're going to see another one of their patients and you're going to want to call them. And so just this is granular stuff, but just keep going back to that, because that's another way to keep connections and relationships going and resources. Lauren.
Awesome. I really appreciate everybody's time and the panelists' time. I feel very validated by kind of hearing from you guys, and really appreciative of the kind of the thought that it takes time. And I am definitely always one. I just want to hit the ground running and be there and doing it right away. But that it takes time to get settled and to learn, to build relationships, to really understand a system. And that, I'm also struck by how we kept coming back to the relationship building piece. And, I think it is Consultation-Liaison Psychiatry. And I am here in part because I really just love that liaisoning piece, and maybe others do too, but that's such the relationship building is so core in the mentorship piece. And I'm super excited for this mentorship kind of experience that PIC is organizing. But yeah, thanks everyone for coming.